Welcome, everyone, and thank you for joining today. My name is Lily Stavisky, and I'm a part of the BHIPP team. A few things just to remember. If you're participating today to receive CME or CU credit, you'll need to attend for 45 minutes or more to receive your certificate. And all participants who'd like to receive credit will need to complete the evaluation survey at the end of the session, and we will put that in the chat for you at the end and also send an email after the session. And certificates will be sent out by November 7th, along with a link to the recording for today's session, the PowerPoint slides, and related resources. And all of those materials will also be uploaded to our website as well. I will be introducing our presenters today and facilitating our Q&A at the end of the session. For those of you who are unfamiliar with BHIPP, I'd like to provide some information about our program. So Maryland Behavioral Health Integration in Pediatric Primary Care, or BHIPP, is a child psychiatry access program that supports the ability of pediatric primary care providers and emergency medicine professionals to address and manage mental health concerns. BHIPP is a free statewide program that offers telephone consultation, resource and referral networking, telemental health services, and training and educational opportunities. The BHIPP consultation warm line is staffed by a team of child mental health specialists and is available Monday through Friday from 9 a.m. to 5 p.m. And our phone number and website will be placed in the chat for you. It's my pleasure to introduce today's BHIPP Resilience Break, Managing Side Effects of Psychiatric Medications in Pediatric Primary Care, Practical Tips and Clinical Pearls by Dr. Mark Riddle and Dr. Sarah Edwards. Dr. Mark Riddle is a professor of psychiatry and pediatrics at the Johns Hopkins University School of Medicine and former director of the Division of Child and Adolescent Psychiatry. His current clinical work involves providing phone consultations and training to primary care clinicians. The focus of Dr. Riddle's research, teaching, and clinical practice is pediatric psychopharmacology, especially medication side effects. His publications include over 300 research articles, reviews, chapters, and edited volumes, including Pediatric Psychopharmacology for Primary Care, published by the American Academy of Pediatrics. He serves as a member of the NICHD-sponsored Data Monitoring Committee for the Best Pharmaceuticals for Children Act, and as chair of the Scientific Council of the Nonverbal Learning Disorder Project. He was a member of the Institute of Medicine's Committee on Review of Pediatric Studies conducted under the Best Pharmaceuticals for Children Act and the Pediatric Research Equity Act, and was the founding chair of the Interventions Review Committee for Disorders Involving Children and Their Families at the National Institute of Mental Health. Dr. Sarah Edwards is an associate professor in the Department of Psychiatry and Pediatrics at the University of Maryland School of Medicine. She is the director of the Division of Child and Adolescent Psychiatry and the medical director of Child and Adolescent Psychiatry Clinical Services at the University of Maryland's Children's Hospital. She oversees and provides direct pediatric mental health treatment in the inpatient, ambulatory, and consultation programs at the University of Maryland Medical Center. Her research interests involve early childhood mental health, trauma-informed care, and pediatric integrated care. We are very grateful to have you both here with us today. Thank you so much for sharing your expertise with us during this session, and I will hand it over to you guys.
Thanks, Lily. Just one question. Who is going to run the slides?
I'm advancing them for you, Mark. So just let me know when to hit.
Okay, ready to go.
Okay. So disclosures. Dr. Riddle's an employee of Johns Hopkins and receives funding from BHIPP, and I'm an employee of University of Maryland and also receives funding from the BHIPP state grant. There you go, Mark.
Okay, so we have 3 learning objectives. They're to identify and manage side effects of medications for ADHD, for anxiety and depression, and other medications for psychiatric disorders. Next. So our dilemma regarding side effects are that there are too many medications and too many side effects and limited time and limited reimbursement. Next. Other similar dilemmas are, say, the number of preparations for ADHD. There are about 20 for methylphenidate, about 15 for amphetamine, way too many to have them all clearly in your head. Another example would be Psychiatry's Diagnostic and Statistical Manual, the DSM. And I pick here anxiety as an example. So there are 5 anxiety disorders: separation, specific, social, generalized, and panic. If you think about a panic attack, there are 14 possible symptoms. And for each of the 5 disorders, you need to know how many symptoms are needed, the age of onset, the duration of symptoms, and the distress or impairment. So that's 5 times 25 things to remember, way too much. We just basically simplify that by thinking developmentally. Separation, fear of losing a caretaker; specific, fear of things in the environment, dogs, lightning and thunder; social, fear of humiliation or embarrassment; generalized, worry; and then finally panic. And those come along developmentally for children and are pretty easy, I think, for most primary practitioners to diagnose and understand without memorizing the DSM. Next. So what to do about the number of medicines and side effects? Well, keep it simple, but without dumbing it down. So reduce the number of medications needed to provide quality care. Prioritize the medications with the best side effect profiles. Try your first choice medicine, if needed, second choice medicine, and if both fail, consider consulting BHIPP. Next. So reducing the number and prioritizing medication. So I mentioned the problem is too many medications. If you look at the app that the European College of Neuropsychopharmacology has, called Neuroscience-Based Nomenclature, you'll see that there are over 110 psychotropic medications, most of which are available for prescribing in the US. And clearly that's too many. So our proposed framework is to keep the group of medicines that are safe and effective relatively small. Next. So the conceptual framework, medications are prioritized by safety and efficacy, and then secondarily, provider comfort, that's generally FDA approval; convenience, generally once daily dosing; and cost, that a generic is available. Next. And using that framework, we've come up with 3 groups of medicines. The one we're going to focus on here mostly is group 1 for ADHD, anxiety, and depression. Group 2 are for disorders like psychotic disorders, mania, and irritability, and autism, including second-generation antipsychotics and lithium, which are more toxic medications and generally aren't part of primary care. And then group 3 are other medications that you probably won't prescribe, but may see in your practice, and some familiarity may be useful. Next. Now, what about evidence of efficacy? I think you probably all know this. There's not a single gold standard, but the FDA requires separation from placebo in 2 well-designed randomized clinical trials. Because studies in youth are much more difficult to do and less common, the FDA sometimes accepts 1 high-quality study, and you can look up what has been studied in by the grade work group online. Next. Evidence of safety is less clear. We came up with 5 parameters, and I think they're worth reviewing. So FDA approval requires evidence of short-term safety, anywhere from 6 to 12 weeks. Sufficient exposure, that the drug has been on the market at least 10 years, minimizes the risk of rare adverse events, because within 10 years, there should have been enough of that rare event to catch the eye of the FDA. The third is no substantive FDA boxed warnings. A boxed warning is only supposed to be used for serious adverse events. And so if there are no substantive warnings, we don't have to worry about serious. Minimal overdose harm, that reduces the risk of accidental and intentional harm. And accidental can include little brother or sister knocking over a medication container, the pills spill out and become candy and can lead to real tragedy. And then finally, no or minimal known long-term risk. There's no way to study that, but I think all of the medicines we'll be talking with you about have been on the market for at least 30 years. And so having no real known long-term risk is fairly well established, and over time will be even more well established. Next. Now, these slides aren't very fancy, and I think there's a good reason for that. I'm going to review the FDA and adverse effects for fluoxetine. And the date here is 10/21, but it's been updated since, and there's no real change. So there are boxed warnings for fluoxetine for suicidal thoughts and behaviors. There are contraindications for serotonin syndrome and QTC prolongation. There are 14 warnings and precautions of considerable concern and 22 adverse reactions. An adverse reaction is identified by the FDA as occurring in greater than 5% of the participants on active medication in a study and being at least twice the rate in placebo. So there are 22 of them, and then there are drug interactions that are listed here. You can look this up, at www.accessdata.fda.gov. The FDA, as you probably know, now has a first page on their package insert, which may run for 20, 30, 40 pages. But that first page has all of this stuff plus more. It has everything you need. Next slide. So we're going to run through those 14 warnings and precautions for Prozac. So suicidal thoughts and behaviors in children is the first one. Serotonin syndrome is the second one. Next slide. So for the suicidality in antidepressants, I just want to review that. It's not as serious as everyone thought. So in 2006, which is between 15 and 20 years ago, there were 4,300 children and adolescents in studies of antidepressants. 4% on active medication and 2% on placebo had suicidal thoughts or an occasional attempt. So the difference was 2%. When the data set got up to 5,000 several years later, it was 0.7%, and at 6,000, 0.9%. So our way of thinking about it is it's probably real in about 1% of the children and adolescents that we treat with an antidepressant. So that's 1 out of 100. We think it's probably due to behavioral activation, and we recommend monitoring for safety. If the family knows that this is rare, but it could happen, and to let you know if it starts to happen and have the child or adolescent let the parent know, it can be prevented. I have a note at the bottom. After all this was formalized by the FDA, several scholars looked at paroxetine or Paxil and venlafaxine Effexor, which, because of their pharmacokinetics, might be expected to be more of a problem, found that they had the highest rate amongst the antidepressants. And if you took those two drugs out, there was no effect. But although that warning should probably go away, it won't, because no FDA director is going to want to have blood on their hands after they take it away and then a child taking medication suicides. So it's there, but you can manage it. Next. Serotonin syndrome. I've listed here the 4 major categories of symptoms: GI, mental status, autonomic instability, and neuromuscular. And I put in blue those that I try to remember, too many to remember all of them. And at least in my experience, 5-hydroxytryptophan supplements, which are used fairly commonly, and this is the precursor for serotonin, and triptans for migraines are common causative agents. And so I try to just ask about those if I'm using more than one serotonergic drug. Next slide. And I'm going to go quickly now through the rest of the warnings and precautions. So allergic reactions and rash, activation of mania, hypomania, seizures, altered appetite and weight, abnormal bleeding. Next. Angle closure glaucoma, hyponatremia, anxiety and insomnia, QT prolongation, potential for motor and cognitive impairment. Next. Long half-life, and that's just for fluoxetine, Prozac amongst the SSRIs. The next one is the combination medicine with olanzapine, where you see the X's. And then an important one that's last on the list is sexual dysfunction. And Sarah's going to talk more about that later in the talk, but it's obviously important for adolescents. Next. Now, the common adverse reactions, again, these occurred in 5% or more in the kids in the studies, and at least twice the rate of placebo. And I'm just going to read through them quickly. And these were found in adults, children, and adolescents. Abnormal dreams, abnormal ejaculation, anorexia, anxiety, asthenia, diarrhea, dry mouth, dyspepsia, flu syndrome, impotence, insomnia, libido decrease, nausea, nervousness, pharyngitis, rash, sinusitis, somnolence, sweating, tremor, vasodilatation, and yawn. You've got those memorized, right? No, don't try to do it. Next slide. Just a comment about discontinuation syndrome. Now, I've been talking about fluoxetine. It has such a long half-life that you don't see this. But with the other SSRIs, you do. And I have the symptoms in 3 groups. The bottom group is the rapid return of the symptoms you're treating. Irritability and low mood, in depression, anxiety, agitation, sleep disruption. The top are the symptoms that you often see when starting medication, particularly the GI symptoms. And then in between are some minor neurologic symptoms. So if you just remember, and the family knows that if the child abruptly stops the medicine, they might see the symptoms you're treating coming back, plus the GI symptoms. You can usually catch this very quickly and restart the medicine, and the problem goes away. Next slide. Now, just a few comments about medicines for anxiety and depression. And Sarah, is it okay if I call you Sarah instead of Dr. Edwards? I'm so used to calling you Sarah.
You certainly can call me Sarah.
Okay, you can call me Mark. So this, we're going to go back and forth between this slide and the next one. And let's go to the next one first. So if we think about depression, we have 2 medications that are approved by the FDA. Fluoxetine or Prozac down to age 8, and escitalopram Lexapro down to age 12. Now that doesn't mean the others don't work. For example, sertraline, Zoloft, they didn't do a study. You know, this was 30 years ago. Most of the companies thought there's not that much money to make in children with depression, and we're not going to fuss about it. Let's go back a slide. Now, anxiety is busier here, and you'll see the first 3 in the second column on indications has anxiety no and an OCD yes. And that's because the companies didn't do studies for anxiety. But at the time, 30 years ago, when these drugs were being approved, OCD was considered an anxiety disorder. That changed in a recent DSM, although it's so similar to OCD that it doesn't make that much difference how you want to think about it. Anyway, they got those indications for OCD, and that's sort of our proxy for anxiety. Also, where it says no, and is a B level of evidence, those three medicines were studied in large multi-site protocols that were funded by the National Institutes of Health. So there's plenty of good data there. Now, go back for a minute to go forward to the depression slide. If we look at escitalopram there at the bottom, or Lexapro, it just received an FDA indication for generalized anxiety disorder down to age 7. So I'm going to have to remake these slides, and I'm sorry, this is new information and I just didn't get that done. But we now have one of the SSRIs that has that specific GAD recommendation. And if you go back again to anxiety, you'll see that escitalopram is not there. It's a newer drug than those first three that got the indications for OCD. So they went ahead and got something for their medication. And then at the bottom, finally, duloxetine is a serotonin and norepinephrine reuptake inhibitor, and it has an indication for generalized anxiety down to age 6. Again, I apologize for the busyness in the slides. Our approach in BHIPP generally is to focus on 3 SSRIs: escitalopram, sertraline, and fluoxetine, for use either in anxiety and depression. And again, that's what we generally recommend. Duloxetine sometimes, but it's a little more complicated medicine and has a little bit more in the way of side effects than the SSRIs. And Sarah, I think that's my last slide.
Great. Yes. Yep. Thank you so much, Mark, for that really nice conceptual overview and helping us think through in a very, I love your approach, very thoughtful approach of breaking down the complications when we think of like how much information and how many drugs and how overwhelming it can be, but really to kind of simplify from that conceptual framework. So I appreciate that. I'm going to spend the next 20 or so minutes kind of talking about just more clinical pearls, little helpful tips about what do we do when we are discussing side effects with families, as well as just when you're practicing, how do we handle some of them? So I'll start, since we had just finished with the SSRIs, I'll start there and then go to the stimulant medications, alpha agonists, and then we can open it up for some questions. So with that, I do want to first highlight a couple things. I think it's important when we're mentioning and doing informed consent, and you're talking about potential side effects, adverse events, medications, really thinking about how risk is presented. So we know that whether it's absolute risk or expected odds ratios or odds, it can be very confusing for providers, for patients and their families. And importantly, the multiple ways results can be reported can contribute to this problem. So for example, if you take a trial that says 6% of youth receiving a placebo had, let's just say, a headache, and then compared it with the medication, 7% had a headache. Well, that's an absolute difference of 1%, or 1 out of 100. But that relative risk is really 1.18, or an 18% increase. So if you present this risk as 20% increase in risk associated with antidepressant treated youth, it potentially misrepresents both the overall low risk and an infrequent event. So I love, there's a great review article by Strawn et al. It was 2023 and pharmacotherapy that really looks at youth, specifically SSRIs and youth side effects. And they're now starting to think about other ways that alternatives to approach how we present the information about adverse effects. And they gave this really nice visual here. So in here, if you look at reviewing the package insert for fluoxetine or Prozac, 22% of patients who were on Prozac had nausea, compared to 9% in the placebo group. So that represents it's 133% larger incidence of nausea in patients who received fluoxetine compared to placebo, which is a 22% incidence. Or what I like with the little people on the right-hand side, it's an additional 13 out of 100 patients. So, you know, if you were to say the odds of the side effect, it's 2.4 to 1, that's kind of more misleading. But these visual graphs and representations, I think, really do a nice job of presenting it in a way that's more palatable and more meaningful. I threw this slide in here, so hopefully when you get the slides at the end, you can reference this again. This is from the book Pediatric Psychopharmacology for Primary Care. Dr. Riddle is the main author. And I think it is so fantastic to be able to boil all of the really important safety points down to a couple bullet points. And so when talking about this with your families, you know, to talk about how many healthy children do not have any side effects from SSRIs. And then the side effects that we do have, many of them are reversible if you stop the medication or you decrease it. The most common side effects are the GI, nausea, upset, and that typically will go away. It happens usually when it's the medication is started, and it usually goes away in a few days. Agitation or behavioral activation can be common, again, in the beginning or when you're increasing doses, but usually subsides over a few days. Less common, you might see with the disrupted sleep, or conversely being really sleepy during the day, that fatigue and tremor. Adolescents definitely can have some increased sweating. I'll talk more about decreased sexual desire, delayed orgasm. And then specifically for families, a talking point to talk about the black box warning, that we know that suicidal thoughts and behaviors can emerge during recovery from depression. And I love that wording. I don't know how long that took, Mark, for you guys to come up with that statement, but that's a really nice way of presenting that information. That we know that suicidality, meaning the thoughts and behaviors, not necessarily completed deaths by suicide, can emerge during recovery from depression, and that it's 1 in about 100 to maybe 1 in 150 patients taking the medication might have that compared to patients taking placebo. But we are going to partner together between the provider and the family and provide that psychoeducation, and importantly, develop a safety plan to address if the youth were to develop any suicidality. So please reference this slide with these main take-home messages. I think it's a really nice condensed way to keep it all straight. We have a lot to remember when we're talking about starting medications. And I think in certain situations, especially when you're talking about depression or anxiety, the youth is upset, the family can be upset. And when you're doing a very important thing in a shortened period of time, this will keep you on track. So I like to kind of conceptualize the main side effects of SSRIs, or I can't speak today, but as the early emerging ones. So those side effects like your nausea, GI discomfort, the insomnia, tiredness, fatigue, and the behavioral activation, compared to the later, more persistent or late emerging adverse effects. And that's where we talk about more of the weight gain, dry mouth, xerostoma, and then sexual dysfunction. So let's talk about each one and kind of break them down. So anything related to GI discomfort. So we do know that, you know, we have the most serotonin in our gut. And so it's very typical when you first start an SSRI to have some discomfort and nausea. Easy way of dealing with this is to take the medication with food. That seems to help a lot of people. If you're taking it in the morning and people aren't hungry, specifically teenagers, you know, they're basically rolling out to get to high school on time and rolling out of bed. And so a lot of them aren't grabbing food. But if you can even have it with a little bit of crackers or a protein bar as they're in the car on their way, that can really decrease the amount of GI discomfort. For other patients, if that's just not possible, the kid's not eating at all in the morning and it's an issue, you could start when you're taking that medication, you could take it at bed, right? So you take it before you go to bed and then you would sleep through any of that GI discomfort. So that's one of the kind of clinical pearls and things to remember. When we're looking at insomnia, certainly part of that behavioral activation, some people do feel like it's harder to fall asleep, feel a little bit more kind of on edge, a little bit more keyed up. And so that can have problems, especially starting the medication with falling asleep. So there we're really focusing on the maximum concentration of the medication. So you want to take it in the morning, because with that Cmax or the maximum concentration, you want that to happen during the day rather than in the evening. That would keep somebody up and contribute to kind of more of that activation feeling. So if you're having problems falling asleep, tell them take it earlier, especially with teenagers. If they're waking up late on the weekends and they want to take it at noon, 1 o'clock, well, that could contribute to that. So try to have them take it early. Conversely, if some SSRIs, more so than other, can definitely cause some daytime sedation and sleepiness, tiredness, well, then you want to just take it in the evening. All right. So it depends. Everybody's a little bit different. We know that medications like mirtazapine, Remeron is definitely more sedating. So that tends to be taken at night. Really, everyone's body is a little bit different. So sometimes you just have to have them start taking it typically in the morning, and then you can figure out if they're having any of the side effects. But we have to ask. And sometimes I think all providers, busy clinicians, sometimes don't break it down. And typically, if we don't ask, people don't mention it. Dr. Riddle spent a lot of time already talking about kind of the suicidality, but more along the lines of the behavioral activation. That is something that we see. It's more common in younger children. Think of it as like having, some adults have described it as like having too much caffeine, kind of feeling that internal restlessness, a little bit more impulsive, kind of when you're keyed up, you might be a little bit more agitated, and then a little bit more disinhibited, right? So you're just going to kind of react. And the way to target that, if you've noticed that as an adverse or side effect from the medication, is we really want you to, this is why we tell you to start low and go slow. If let's say you started somebody on escitalopram or Lexapro 10, and they start becoming a little activated, then bump it down to 5 milligrams and then titrate more slowly. So that's how we target it, but it doesn't last that long, and it's all, you really just want to slow down your titration. Weight gain. So the data concerning weight gain in SSRI treated youth really has produced kind of mixed results. Again, in the review by Strawn in 2023, he mentions that weight gain with SSRIs, you can see it more in the treatment emergent, but typically it's more later, and it definitely persists. I know that for adult patients, it very much is an issue. And it's more longer, kind of like when somebody's been stabilized on an SSRI and then they realize, oh yeah, when I look back, I really, I've gained a good 10, 15 pounds, but it's always about risks and benefits and weighing those. And so if you're getting a lot of positive effects, if your depression is decreased, your symptoms and your anxiety is better, then you want to see what else you could do if there's other ways to alleviate the weight gain. In the Strawn review article, they did mention that for looking at the data in prospective studies of youth with anxiety and depression, they specifically mentioned paroxetine or Paxil and citalopram or Celexa as the two that were most associated specifically with youth and weight gain. And those two aren't the ones that we, when we talk about the three that we typically try to minimize, make it a little bit easier and manageable when you're choosing SSRIs. Those aren't our two go-to for youth and children, but I did want to put it since it's in the review article. I also think it's hard to, when we talk about weight gain, because it's a appetite, changes in appetite, it's associated with the underlying disorder of depression, right? We know that, and with anxiety. And then with kids, sometimes these effects are really difficult to detect because of just the given age and sex related developmental shifts in weight and growth trajectory. Also, when we look at Dr. Riddle mentioned as far as FDA approval and clearance, there's short-term nature of most of those clinical trials. So they're only talking 6 weeks to maybe 12 weeks. And so with all of that, sometimes it's hard to kind of tease apart. But I can just definitely say in adults in general, it is a common side effect with SSRIs. I threw this in for your reference later on. It's from a nice review article back in 2003. But this is specifically for adults, but it kind of groups the different antidepressants and then the impact on body weight. So as you might be aware, their MAOIs are definitely associated with more short-term weight gain and long-term, your tricyclics. SSRIs, less short-term. Sometimes people do, because of that behavioral activation, might initially lose a little bit, but then long-term is definitely possible. We know that Paxil's one that paroxetine is associated with short and long-term weight gain. Bupropion or Wellbutrin, less likely to cause weight gain and typically can cause weight loss. It's an ingredient in many of the weight loss obesity medications. And so that is one of the ways in which we treat weight gain. And then mirtazapine or Remeron, as I mentioned before, is one associated with weight gain. So what do we do? Well, not that it's ever easy, but we need to monitor our diet and exercise. So sometimes patients are going to benefit from nutritional counseling, maintaining a food diary. Nutritionists can work with you and work with patients to kind of keep that diary, do some behavioral activation, which is going to be helpful for mood as well as then potentially treating this adverse event. And then looking at like things such as maybe smaller meals, decreasing the frequency, increasing the meal frequency and decreasing the amount on a plate. In general, you could switch. So if somebody has gained a lot of weight, but maybe is stable, potentially you could switch medications. However, you have to weigh that risk and benefit. And so switching carries the risk of the loss of the clinical effect. In adults, I haven't done this as much with adolescents, but with adults, certainly not necessarily a lot of strong literature to support this, but in clinical practice, sometimes people add a little short-acting stimulant, specifically around lunchtime, so that for that meal, there's a decreased total amount of caloric intake, which might be enough to kind of offset the overall increase and then to help diminish the weight gain. Also, if you don't want to switch from an SSRI, especially in adults, frequently psychiatrists might add just a very small dose of Wellbutrin, bupropion, and that can help to diminish some of the weight gain. When we talk about dry mouth, this is an important one. So many different medications cause dry mouth. I just took my antihistamine because I have horrible allergies at this time of the year, and that's a medication that I know definitely dries me out, right? And so our psychotropics, specifically SSRIs, definitely have this side effect. And it's really important to remind patients to stay well hydrated, so to drink lots of water. And anytime we put something in our mouth, it triggers natural saliva production. So encouraging, if somebody is having the side effect, to chew some sugarless gum. You want to avoid caffeine and alcohol because they're diuretics, right? So that's going to make you even more parched. But you can specifically you could use any sort of sugarless gum, but in the dental aisles where they have the toothpaste and the dental floss, they have specific different brands. Biotine is one of them. They have little lozenges that you can put in your mouth, and it'll help to, again, produce that saliva. And then if you have a dry mouth moisturizing gum, that actually has some xylitol in it. And some of the other gums might have like glycerin or some other hydrating agents. So that'll help with the dry mouth. So a lot of this is available at your local drugstores or on Amazon. And sometimes families don't know about it. So it's important to kind of just have this in your back pocket. Now on to sexual side effects. So super important, and something that, guess what, we don't do a very good job of discussing or checking in. Definitely do better, I think, with the adults, not so much with the adolescents, and it's so important to discuss. So you have to, I boiled it down, and there's a great pediatrics review article from 2014 that said, like, do it into these 3 buckets. And you have to ask these questions specifically. Because if you just say, hey, are you having any sexual side effects? A lot of times people are like, no, everything's good. But ask very specific. So have you ever experienced a change in libido? And so spell that out, sexual desire, thoughts, or interest. Have you ever noticed a change in orgasm since starting the medication, such as a delayed orgasm or not being able to achieve one? And then have you had any difficulties obtaining an erection? So I can tell you a story that I was working with a young adolescent male who was probably 17, maybe he had just turned 18. This was in one of our Department of Juvenile Services site. And he told me that he was really, really upset. He had been started on years ago because he was definitely anxious, and I wanted to start an SSRI. And he had given a story that somebody had started one on him before, and nobody had told him about the potential for sexual side effects. And he didn't say it in the same language I will say. However, basically was saying he was so worried. Nobody told him about it. And here he's a typical young man masturbating, 3-4 times a day, he's like, I could look at a picture and be done. And guess what? He started this medication, and he noticed, a very delayed orgasm, and he was really worried that there was something wrong with him. He's like, oh my gosh, what is wrong with me? What is going on? He had no idea that it could have been from the medication. He was super worried about this. So here was somebody who was already depressed and anxious, and now he had this new worry, and he really thought something was just medically wrong, and was embarrassed and didn't want to, talk about it. And it wasn't until he just got fed up and had stopped the medication for something else. And then later, when I was telling him about it, that he was kind of like putting it all together. So it's really important that we do talk about it. It's actually really common. So the adult literature says that probably about, as much as 50% of adults experience some sort of sexual side effect. Again, it's hard to tell because we're not doing standardized sexual side effect assessments. It's not like we're doing the scales. And so it's not, we don't have as much objective data. And then because we don't ask, that's why we don't know quite as much, but it's definitely well documented, and it's, really important that we get past kind of feeling a little uncomfortable and talking about it. So what do we do if we have it? So for the low sexual desire, you could definitely switch, if you switch away from to a non-serotonergic drug. Typically though, before you switch, you try lowering the dose a little bit to see if that helps. Sometimes you can also just add Wellbutrin. Now for the delayed orgasm or inability to achieve orgasm, definitely start with your dose reduction. I have had adult patients where they do kind of holidays, weekend holidays, so they won't take it for a couple of days, and that seems to help. Also, then just consider switching to a non-serotonergic drug. And then for erectile dysfunction, switching to a non-serotonergic drug, usually decreasing the total dose is not enough to deal with that. And then I haven't had to deal with this with adolescents, but with adult patients, I have then just worked with their primary doctors, and sometimes because they've received such benefit from the SSRI and they don't want to stop that, but they're having erectile dysfunction, their primary doctor can go ahead and treat that with other medications. So take home point here, please, really important. We have to ask. If we don't, people could be young adolescents. It's super important, and they can really be worried that something is wrong. So moving along, a couple more minutes talking about stimulant medications. The graphs here again show which we have so many. It's great that we have stimulant medications. We have your amphetamine class, your methylphenidate class. Then we can also treat with ADHD medications, your alpha agonists I'll talk about in a bit. And then we have Strattera and amoxicillin. And this was nice, I threw it in here again as a reference. Dr. Riddle, I know you developed this. You have the green, your grid is that the green is that they're expensive. They're not generic. And then the red is that you want to use a little caution because of Like Jornay is one that you take at night. It's very long acting. Bedias is extremely long acting. Vyvanse doesn't kick in right away. And Focalin, remember, is more like an amphetamine. So it's kind of that 2 to 1. And then the blue is that these are nice, easy to use, into usually there's more available. Mark, please correct me if there's anything else in your color coding, which is fantastic. I like this chart, so hopefully the audience will be able to go back and use this. That's it? Okay, great. So what do we do with the side effects? So we know stimulants definitely have side effects, but they're pretty easy to work around. So most common would be your GI, your belly pain at first. Then we have appetite suppression with some weight loss and difficulty falling asleep. So I'll break those down in the next couple of slides. Less common when we think of more of that treatment, not necessarily emergent, but kind of longer term, would be your growth suppression. There was a recent FDA precaution. We do know that the long-acting stimulants, the longer in your body for the more years that you could potentially be using them, that does put you at risk for, decreased overall total height. We'll talk about preschoolers who have dysphoria. Definitely when we're looking at behavioral cognitive constriction, kind of that blunting, I'll talk about that in the next slide, and then tics. And stimulants work they do increase our pulse and our blood pressure. But typically that's not going to it's not going to interfere unless somebody has an underlying condition or heart condition. So our common adverse effects, if the kid is, the Energizer bunny, and then suddenly he appropriately is able to be less impulsive and hyper and is sitting still, but maybe it's just a little bit too much. They're kind of spacey, little too serious, too quiet. Then we want to look at that dose. I'm worried that it's too high of a dose. They should not look zoned. They should still be fully interactive. They should, you still want a kid to be a kid, right? And so you just want to tone down those core symptoms of ADHD in order to function. So typically we'd start by just decreasing the dose and seeing that you could still get the target symptom control that you want, and then hopefully they'll be less spacey. If not, you can switch classes. So if it was methylphenidate, go to the amphetamine. For the rebound irritability, so you can have the long-acting medication, and then in the afternoon, it's that rebound impact. So sometimes we recommend just adding a short-acting. That could be enough to get you through that. Tics. So we're going to monitor for tics, common side effect, but tics are common in children. Latency age children, tics are extremely common. So everything's always about a risk and benefit. If the ADHD medication is helping greatly and they happen to have tics, you can do the wait and see approach. If it's starting to impact their functioning, if they're getting made fun of, then you can try lowering the dose. You can try switching to the different class of medication. And lastly, you can add an alpha agonist if you need be. But remember, we really don't want to be adding medications to treat side effects. So that's why you want to try the other stuff first. But alpha agonists are used to treat tics anyways. With the GI upset, eat before you start the medication, have a big breakfast and then take the medication. And that typically handles that side effect. Headache. Well, common things are common, right? So make sure kids are well hydrated. That's the most common reason for headaches. But sometimes kids do have, with stimulant medication, they can't have a headache with one class, methylphenidate, and not the other. So sometimes you switch classes, but typically try to make sure they're well hydrated and that they're having food before they have the medication first. Now, with the preschoolers, the PAT study, and Dr. Riddle was a lead PI and author of the publications, stimulants, it really helped us figure out, well, can we use stimulants to treat preschool ADHD? And the bottom line is you can't, but we know that it doesn't work. The effect size isn't as great, so it doesn't work as well. And then the little ones have just so many more side effects. And the most common ones really that they feel that appetite decrease. They have that irritability and outburst more. And then depending on again, timing of it, they can definitely have more problems falling asleep. So let's look at some of these helpful tips regarding appetite and weight loss. So here's a great little infographic from Very Well, but it hits all the high points, which is that, if you're starting to have that decreased appetite or weight loss, make sure you have a big breakfast and then give the medication. Make sure that you're having nutritious, high caloric, nutrient dense foods. Schedule your meals when your kids are hungry. You know, they're not going to be, if they're having their stimulant medication, they're not going to want to have a large lunchtime, right? Maybe you have to move your dinner back a little bit towards the, you know, more like 6 o'clock instead of 5 o'clock. So schedule when the kids tend to be hungry, offer them lots of nutritious snacks, and then also look at the timing of the medication. So initially, a lot of people will experience this. Kids are more susceptible, but frequently your bodies do get used to it and it doesn't end up having as much of an impact. And that's why we know that stimulants aren't the be all end all for adult obesity, weight loss management, right? So they can work a little bit, but eventually your body can become used to it. These are the important kind of pearls and clinical tidbits to help you. The other thing to remember is if a kid is not going to eat a big lunch, that's okay. They'll make up for it later. But that's why you have to allow them to have access to healthy snacks. Consider drug holidays as well. If they can function, if you can handle their untreated ADHD symptoms over the weekends, give them the holiday. If that, you know, talk about it with the families, and that's always an option. I love this. A lot of the next couple of slides are from clinical pearls and working with my pediatric colleagues, as well as pediatric GI specialists. And so things to add, if they are losing and you need to add some calories. Breakfast, look at adding butter to things like oatmeal or grits. Make sure add peanut butter to fruit. So don't just give a sliced banana, give a peanut butter and banana, peanut butter and apples. If you're making scrambled eggs, add cheese to it. Make sure you're using whole milk to scramble those eggs. And don't allow them to drink during, only have them drink after, so that way they're finishing their whole meal. For lunch and dinner, same sort of things. Add butter if you're doing pasta, mac and cheese, add butter. To the vegetables, sprinkle cheese on top of the vegetables, put butter, melt them with, you know, lots of butter. Things that I wish that I needed to add calories to my own diet right now, because this sounds fantastic. But add cheese to little things, use regular salad dressing instead of the fat or low calorie. Lots of whole milk, and same thing with the drinking. Make sure that you eat before you finish your drinks. Let them eat snacks, healthy snacks, up to 3 snacks a day. Regular yogurt, not the low-fat yogurt. These are good ones. And then the fruit, we talked about the peanut butter or hummus, you know, hummus with it. In general, drinks, so whole milk, don't be using the 1 or 2% skim. You can add 1 or 2 spoonfuls of even whipping cream, like whipped cream to the milk, to a glass of milk. And that's going to give them like more calories. Things like extra supplements, Carnation Instant Breakfast or Pediasure, really great choices. And I'll show you, you can go on their websites. They even have some different recipes to bake with it. So I'll show you that in a second. Don't give them juice or soda just to get the calories though. It's bad for their teeth. It contains sugar. You can make the shakes. You can make smoothies. And there's lots of good ways to get those extra calories. So Carnation Instant Breakfast comes in packages. It comes in the pre-made bottles. The packages are cheaper. Do it with whole milk. And you're going to get one of these packets has as much as the protein as 2 eggs, as much calcium as 3 cups or 5 5-ounce cups of Greek yogurt, as much vitamin D as 3 8-ounce glasses of milk. So they're very packed with nutrients and protein. Peds GI specialists, my colleagues here at Maryland, love them. The new flavors are quite incredible. So I like the Girl Scouts. They have a thin mint, they have a coconut caramel, Golden Grams, Fruit Loops, you name it. It seems that they're really trying to encourage and make sure, because like kids, like most of us, are going to get sick of maybe just the chocolate, vanilla, strawberry, and they have these great fun flavors. Go to their website. They have these recipe mix-ins. So even if the kid is sick of like, stop it, I don't want to drink this milkshake anymore, you can add the powdered to direct recipes. So there's a French toast bake, and there's yogurt ice pop bars and breakfast bars and muffins, and that's just a great way to make sure that you can get those calories in that are, you know, more nutritious and with a supplement. So this is a neat thing that not everyone's aware of. when we're talking about stimulants and sleep issues, it's about changing the timing of the medication. So if you give it later, yes, they're going to stay up late. But even some kids, especially the younger kids, can be just more susceptible. So, really work to have the medications earlier. Try that first. In general, when there's still insomnia issues, you got to go back to basics. Look at their sleep routine. No electronics before bed, at least 1 hour before bed. You can also try kind of the sleeping environment, making sure there's some white noise for relaxation. For teens and insomnia, let's bring it down to kind of harm reduction, because kids are still going to have their screens. They're not going to give them to you. Hopefully that could be a practice, but it's really hard. So I try to propose more of the harm reduction approach. So depending on what they're doing, passive use is better than active. So watching TV is going to be less stimulating than doing a video game. Depending on what you're watching like a documentary is less stimulating than watching something scary and suspenseful. So smaller screens better. So this is where the phone is actually better than like a 60-foot TV, because the amount of blue light is greater in the larger the device. You can try, there's blue light blocking glasses, and there's an app for the screen as well. So just some tidbits on how to do that. And then real fast, because I know, yes.
I was going to say, I think maybe we should stop and take some
Yes.
questions real quick.
That would be
We
great.
had a
Thank you
couple.
for cutting me off.
No
Absolutely.
problem. So we had one in earlier, and it said, is it generally safe to give methylphenidates with fluoxetine? Also, is EKG needed before starting fluoxetine to check QT prolongation?
Mark, do you want to tackle these however you'd like to do them? You are muted if you're speaking.
Go ahead, Sarah.
Okay. So I'll do the last one first, which was, do you need to do an EKG for QTC prolongation on starting an SSRI? Is that it for Prozac? And you do not. That is not part of routine workup prior to starting an SSRI. And the first question was regarding, is it okay to give methylphenidate and fluoxetine together? And yes. It's a common medication combination that we use frequently. We know that, ADHD is highly comorbid with depression, anxiety. So it's definitely something that is done. If the youth might have, if you know that they're a poor metabolizer, there could be, some other considerations, or if they have another medical issue, but in general, it's safe. Mark, do you want to add anything on that?
No, I think that's good. I wanted to offer a comment. If we're not going to get to talk about the alpha agonists, just to say that they're amongst the safest medications that we have, and particularly guanfacine or Intuniv given at bedtime just doesn't have much in the way of side effects. The other is that in the question and answers, there's a comment. I thought that the black box for SSRIs reason suicide was just for ideation and not for suicide. And there, I guess I wasn't clear. The suicidality is suicidal thoughts or suicidal behaviors, not a completed suicide. So the person raising that comment is correct. That's it.
We had one other comment that says, anything for milk allergy children for weight?
Milk allergy. I would, let's see, I'd really be reaching out to probably my peds GI colleagues to get some other ideas. I can't think of anything off the top of my head. I know that you could look to see on some of the different supplements. I'm sure it's available, and I don't know which ones specifically. That's a great question. I'll do a little research on that. Yeah, I was going to say real fast. I know we have 1 minute.
Go for it.
Okay, I was going to say with the thank you, Mark, for mentioning the safety of our alpha agonist. It's a great, definitely use a lot of alpha agonists in child psychiatry, guanfacine and clonidine, and then you have the long-acting Intuniv and Cafe. And put in the dosing chart for you here. The common side effects are kind of what we like from them, which would be, this way. is that they are sedating, right? So that a lot of times we're capitalizing on that side effect when we're helping to treat comorbid behavioral issues and insomnia with ADHD. And so you can give the medications, like Mark was saying, when you give them at night, really the amount of side effects, yes, it's going to decrease. These medications were antihypertensive medications, and so they do decrease your heart rate and blood pressure a little bit. But in general, kids are really healthy and have great compensatory mechanisms, so we don't see a lot of the potential side effects from that. And helpful tips would be you want to just use the timing of the medications to your advantage, right? So plenty of prescribers will give long acting in the morning, especially if that's helpful to help the focus and concentrate. If it's a little bit sedating, then sometimes they want to give it at night to help the kid who might have some restless sleep through the night, and then it still seems to help with treating the inattention and focus issues during the daytime. In general, though, again, body does build up some tolerance. And so these typically, if it's too sedating, decrease the dose. And then additionally, your body will kind of get to that. Last slide was about other psychotropics, because we did say that was not our learning. But in general, we want you to stick to, if you have specific side effect questions when we're talking about antipsychotics and other psychotropic medications, give us a call. There's so much to manage, and really, if you could focus what was presented in this lecture, that's what we'd like you to do. So here's some citations with some of the more recent ones. You'll get a copy of the slides. You'll also get a copy of a handout with all of the how to increase your caloric intake. It's a one-pager that you can give to families. And with that, I just want to thank you. I think I'm 1 minute over, so my apologies. And I hope everybody has a wonderful day and has a good Halloween today.
Thank you so much for that wonderful presentation, Dr. Riddle and Dr. Edwards. And to our participants in today's session, there were a few recommendations for a substitute for milk that were placed into the chat, so you can take a look at those. And the recording for today's session, the slides, and a list of related resources, and the additional handout that Dr. Edwards mentioned will be available on our website next week. We will send CME and CEU certificates to participants by November 7th. And please remember to take the survey that was placed in the chat as you exit, as this is required if you'd like to receive CME or CEU certificates. And stay tuned for other trainings. And thank you again so much. And I hope everyone has a great rest of their day.
Thank you so much.
Bye-bye.
Bye-bye. Take care.